Yes, but there's some echo.
Yeah, there is some echo. Now it's better.
Yes.
So thank you, Dr. Neeta and Dr. Caesar, for this wonderful opportunity. And it's an honor to be in this August gathering. And we're going to talk about a topic which is not very glamorous, but very important for the patients, their families, and also the doctors. So my interest in chemotherapy-induced nausea and vomiting actually began about a decade back. When one fine day during ward rounds, I noticed that every kid in the ward was vomiting. Every kid, you won't believe, they were just vomiting their guts out, and we're like surprised what happened and why is everybody vomiting and what's the reason. And so we went and did some investigations, and we realized that all the kids had got chemotherapy, and the chemotherapy antiemetic template was not filled. So they didn't get antibiotics. So the person who was prescribing the chemotherapy did not realize the importance of giving antiemetics. And that's the day I said, when I saw these children and their families so distressed, I said, we need to do something about this. And that's how my interest in this field developed. Can you see my slides? Is it full screen?
Yes, no.
Yeah. So chemotherapy-induced nausea and vomiting affects a large proportion of children who are receiving moderately or highly mutated chemotherapy, and this ranges from 30 to 50%. And when I say 30 to 50%, this is every cycle. And there are children who get 6 cycles, and if you are an Ewing sarcoma, you get 14 cycles. So the number of cycles varies. So at some point that during some cycle, every child ends up vomiting. So, it's not a small thing. It's a big thing for everybody. It is very difficult to assess in a young child. They don't tell you that they have got nausea. They just say their tummy is aching. They become listless. They stop eating. So unlike adults who can tell you, I'm feeling very nauseous. I don't want to eat, or I feel like vomiting. Children do not tell you. And so it's very difficult in a 5-year-old or 2-year-old to really assess the impact of nausea and vomiting in them. And nobody wants to do research in children. This is not lucrative for pharma companies. It is not immunotherapy or CAR-T. It's not $1 million. The population is limited, so nobody wants to do research. Even if they do research, most of the antiemetics are developed in adults, and then it's left to pediatric investigators to bring them and try them in children. So there is very limited research and very limited data on antiemetics in children. So let's go back to our physiology classes. Nausea and vomiting is a complex phenomena, but it's easy to remember that nausea and vomiting are initiated by a group of neurotransmitters. I've been shown them all. This includes your dopamine, serotonin, substance P, acetylcholine, histamine, endorphins. And these can either be released in the gut or in the central nervous system. Ultimately, what happens is that when you give chemotherapy, the gut receptors are stimulated, or the chemotherapy trigger zone in the pons is stimulated. Both of them send signals to the vomiting center, which then activates your muscles of salivation, your pharyngeal muscles, your GI muscles. That leads to the actual process of vomiting. So all the drugs which control chemotherapy-induced nausea and vomiting basically counteract these neurotransmitters. So you have anti-serotonin, anti-dopamine agents, substance 1 blocking, neurokinin 1 receptor blocking agents. So this is the basic pathophysiology. And the idea is that if you want to prevent or if you want to treat chemotherapy-induced nausea and vomiting, you need to act both centrally and both peripherally. That is, you want agents which block the peripheral receptors, and you also want agents which cross the blood-brain barrier and block the central receptors. So that's why most of the patients receiving moderate to highly mutagenic chemotherapy receive at least 2 to 3 drugs with varying mechanism of action to stop or to treat vomiting. Before I go on to my talk, there are certain definitions which I'll be using throughout my presentation. Various studies have used these arbitrary definitions on how to evaluate vomiting or nausea. So the acute period for vomiting is defined as any vomiting which occurs from the start of a chemotherapy block to 24 hours after the chemotherapy block. For example, if you are given a child ABVD chemotherapy or a single dose of high-dose cyclophosphamide over 3 hours, from 24 hours from the start of that cyclophosphamide to next day 24 hours is the acute period. If a child gets a 5-day chemotherapy, say daily ifosfamide and etoposide, this acute period in this child includes this 5 days of ifosfamide and etoposide and 24 hours later, which is day 6. So a 5-day chemotherapy, the acute period. So I'm getting a bit of background noise. So the 5-day chemotherapy, in a 5-day chemotherapy, the acute period extends for 24 hours after the last dose of chemotherapy in 5 days, which is 6 days. So it doesn't mean that you give the first dose of IE and the 24 hours later, the acute period gets over. So this is something which is very important to remember. The delayed period is defined as 24 hours, that is after the acute period, till 120 hours, that is 5 days. You might ask why 120 hours, why not 96 hours, why not 144 hours? I think this has just been arbitrarily chosen by trialists because they wanted to complete their studies at 120 hours. But there's been data that people continue to vomit after 120 hours. So some people are collecting extended data for 7 days, 8 days, going up to 196 hours. And then this is one chemotherapy block, and then you go to the next chemotherapy block. When you combine the acute period and delayed period, it's called as the overall period. Please remember these definitions because all the studies I'm going to talk to you are based on acute, delayed, and overall. Generally, acute period occurs due to your gastrointestinal stimulation, whereas delayed period is more because of your central nervous system activity. And we all know that all types of chemotherapy occurs in various fashions. You have the what is called as breakthrough chemotherapy. You have a child who walks in for chemotherapy. You give your antiemetics, you give the chemotherapy. You expect the antiemetics to work and the child to not vomit, but the child vomits on the second or third day. There is a big breakthrough despite giving adequate prophylactic antiemetics. So this is called as breakthrough CINV. Next is anticipatory. Even before you give a child a chemotherapy, the child is so scared of the medicine that he starts having nausea and vomiting. And this is usually because of, traumatic experience due to chemotherapy-induced nausea and vomiting the previous cycle. A child keeps on vomiting, and next time when he thinks about chemotherapy or a drug, he starts vomiting. This has more of a behavioral component, usually doesn't respond to pharmacological therapy, and you need to use psychological techniques to, control anticipatory vomiting. Then is refractory. You do everything. You gave 2 drugs to control vomiting in the first cycle. The child vomited. So you added 1 more drug in the second cycle. The child continues to still vomit after that. Then it's called refractory. That is, nothing seems to work. You keep on giving chemotherapy, the child keeps on vomiting. So you have your breakthrough vomiting, anticipatory vomiting, and refractory vomiting. As clinicians, we need to know all this because our treatment strategies will depend on what type of vomiting we are dealing with, what type of drugs the patient has got, and that's why it's important to know these types of CINV. I've been talking about moderately emetogenic, highly emetogenic, minimal, low. What do I mean by this classification? This classification means that what is the emetogenicity potential of a drug? Suppose if I give a chemotherapy agent to a patient without any antiemetics, if 90% of patients would vomit, then it becomes a highly emetogenic drug. If 30 to 90% would vomit without prophylactic antiemetics, it becomes moderate. Low is 10 to 30%, and minimal, less than 10% of patients vomit with adequate prophylactics. So some drug like inclisiran, you don't expect patients to vomit. It's like less than 10%. But you give actinomycin, the dacarbazine, these are highly anti-emetogenic drugs. If you don't give cisplatin, if you don't give adequate prophylaxis, you would expect most of these patients to vomit. It is important to classify the drugs based on emetogenicity because it helps us decide what type of prophylaxis and how strong prophylaxis you want to use to prevent vomiting in these patients. So this table tells you about the classification of emetogenicity between adults and children. To the right side, you would see the adult classification. On the left side from mine is a pediatric classification. Children are not miniature adults. They metabolize drugs differently from adults. They handle drugs differently. So there are certain drugs which are highly emetogenic in adults, but are moderately emetogenic. There are certain doses which differ in adults and children. So when the problem is that although this classification exists, but there's very limited data on the emetogenicity of chemotherapy in adults. And when there is no data, we end up extrapolating from adults. For example, you take a drug like cyclophosphamide. Cyclophosphamide has an emetogenicity potential of in adults. In children, we take it up to 1,200 milligram per meter square. Whereas, in adults, it is 1,000 milligram per meter square. So kind of, in adults, it's 1,500 milligram per meter square. So this kind of varies from pediatric to children and adults. I have covered the pathophysiology of vomiting. I have covered the types of vomiting. But now let's go to the actual action, which is how do we stop vomiting? What do we do in the clinic tomorrow and to stop vomiting? And basically, these are the 4 different classes of drugs which we are going to use. Steroids have been the backbone for last 5 decades, and dexamethasone is a preferred drug. Then you have the 5-HT3 receptor antagonists. The common ones are ondansetron, valnocitron, and granisetron. This works against serotonin. Then you have the NK1 receptor antagonist, which works against substance P. You have aprepitant and fosaprepitant. And then recently we have an antipsychotic. You might be surprised that you're using an antipsychotic. Yes, olanzapine is used for treating schizophrenia and psychotic disorders, but this is called as drug repurposing. When a drug is used for another indication, it's a cheap drug, and it was found to be effective in adults, and now it's been shown to be effective in children. So olanzapine is also an effective agent as an antiemetic. And added to this, we have ginger, yoga, acupuncture, and various other home remedies. And these still don't have much of evidence, but have been tried. So suppose you want to find out what is available on pediatric nausea and vomiting. There are various guidelines. So you have guidelines from the Pediatric Oncology Group of Ontario. These guidelines are endorsed by the Children's Oncology Group of USA and the Multinational Association for Supportive Care in Cancer. These are the most latest guidelines. Then you have the ASCO guidelines from American Society of Clinical Oncology Guidelines of 2020. This is also endorsed by the Children's Oncology Group. And then you have the Multinational Association and the European Society of Medical Oncology Guidelines of 2016, which is also endorsed by COG. So you see, among all these guidelines, the POGO guidelines is the most recent guidelines in 2022, and is most commonly used by pediatricians. And therefore, I would be discussing mostly the POGO guidelines in my next few slides. So what do the guidelines say? So for a highly emetogenic chemotherapy, ABVD, ifosfamide, adriamycin, vincristine, actinomycin, cyclophosphamide, cisplatin-based chemotherapy, anything which has more than 90% potential of nausea and vomiting, the current recommendations are to use a 3-drug combination. I've already told you we have steroids, we have 5-HT3 antagonist, we have NK1 receptor antagonist, and we have olanzapine. So the 3-drug combination is usually a 5-HT3 with a steroid, which is Dex, and an NK1, which is the standard. The POGO guidelines says that you can add a 4th drug called olanzapine. But generally, most of us prefer a 3-drug, and the 4th drug is only added if somebody develops breakthrough, or if somebody has a refractory vomiting, that is, has vomiting the previous cycle, is not getting control, you would have. For a moderately emetogenic chemotherapy, that is a 30 to 90% potential of vomiting, the guidelines recommend 2 drugs. That is, they say use steroids with a 5-HT3 receptor antagonist. If you cannot use steroids, for example, in patients with acute leukemia, you would want to avoid steroids, especially in acute myeloid leukemia. You can replace the steroid with aprepitant or fosaprepitant. I forgot to mention that when there are 2 or more drugs which are moderately emetogenic, for example, adriamycin and cyclophosphamide, but when you add them together, the combination becomes highly emetogenic. So it's not, they remain moderately emetogenic. The effect is additive. And if we have two moderately emetogenic, then the emetogenicity becomes one level higher, that is becomes highly. So this has to be kept in mind. So a 3-drug combination is a standard of care for highly emetogenic, a 3-drug with 5-HT3 steroid and NK1 receptor antagonist, whereas a 2-drug combination is a standard of care for moderately emetogenic chemotherapy, which consisting of a 5-HT3 or a steroid. If you can't give a steroid, you can use aprepitant or fosaprepitant. For low emetogenic or minimal emetogenic, usually you can give one drug which is just a 5-HT3 antagonist or no antiemetic at all. So what is this data of, I've been talking about 2-drug, 3-drug, 4-drug for highly emetogenic chemotherapy. And these are the main studies which have looked at highly emetogenic chemotherapy. The first study was by Dr. Bakshi from AIMS, which compared a 2-drug, that is 5-HT3 dex with aprepitant or placebo. And they showed that the total phase, the total phase is acute plus delayed. There's a significant improvement in vomiting control. The same study was replicated by Kang et al., just like Dr. Bakshi, and they still showed that the 3-drug was better than 2-drug. We did a similar study, except that instead of aprepitant, which is a capsule, we replaced it with fosaprepitant, which is an IV preparation given only once a day, whereas aprepitant is given over 3 days. We showed that at least 70% of patients had control of nausea and vomiting with a 3-drug. However, we also included moderately emetogenic chemotherapy patients. And then most recently, it said you can consider adding a 4th drug. This is also a study by Dr. Bakshi's group. When they added olanzapine, they found out that, it's almost double, that is 64% of patients had good nausea and vomiting control. So these are the POGO guidelines, just revising. So if you have somebody with moderately emetogenic, highly emetogenic chemotherapy, the recommendation, if the patient can get fossa or dex, give a 5-HT3 dex and fossa, consider adding olanzapine, continue oral aprepitant for 3 days and dex and your 5-HT3. If you can't give fossa, you can replace fossa with olanzapine. If you cannot give dexa, it's a mix and match, it's like a buffet. You can choose whatever you want. Idea is to have at least 3 drugs based on whether you can give fossa or olanzapine or, a 5-HT3 antagonist. I would like to point out here that there's always been a concern that fosaprepitant and aprepitant interfere with chemotherapy, they increase their drug levels and leads to increased toxicity. I think this has been more of a theoretical concern. We have done trials with these drugs. We use them routinely. In practice, we do not see an increased chemotoxicity with use of 5-HT3 antagonists. Yes, they are costly, almost 20 times costlier than other drugs, especially in an LMIC setting. But the concern about increased toxicity with 5-HT3, an NK1 antagonist in real life is not as much. If you go and read the POGO guidelines, they will keep on highlighting that be careful of NK1 antagonists, be careful of NK1 antagonists. We don't see that. For moderately, I said you have to prefer at least 2 drugs, and the backbone is 5-HT3 with dex. But if you can't give dex, you can give fossa. And the same way, you choose mix and match any of those drugs. You can look at this guidelines. For low emetogenic, a single shot of ondansetron before chemo is enough. And drugs which have no emetogenic potential, there is no need to give any prophylaxis for chemotherapy-induced nausea. The next question is, what's the role of dexamethasone? Dexamethasone is heavily used, and you may be surprised. The initial pediatric oncology guidelines of Ontario recommended a dex dose of 24 milligram per meter square per day. It's quite a stiff dose. And suppose somebody gets ifosfamide etoposide chemotherapy, you have to give dex for 5 days of chemotherapy and another 3 days after chemotherapy. That's almost reaching 250 milligram per meter square of cumulative dose of dex for first cycle. And if you're giving it for at least 8 cycles, it's like almost 2 grams of dex, which I feel is ridiculous. And we are at this situation because nobody has done a study to look at the optimal dose of dex. So there's a systematic review. And what they said that based on adult studies, we can come down. The adults use a standard dose of dex of 20 mg. for highly emetogenic chemotherapy and 8 mg for moderately emetogenic. So the guidelines suggest that if in children, you can reduce it from 24 to 12 milligram per meter square for highly emetogenic, whereas for moderately emetogenic, you can come down to 4.6 milligram per meter square. There is a caveat here. If you are using fosaprepitant or aprepitant, you have to reduce the dose of dexamethasone by 50%. That's because they increase the level of dex in the blood. So this 12 milligram will become 6 milligram if you're using fosaprepitant or aprepitant. And it becomes, if it's for moderately emetogenic, it becomes half of that, becomes 2.3. So this is an important caveat you need to see. I am a firm believer that probably we don't need DEX because DEX is associated with significant toxicities, hypertension, hypoglycemia, mood changes, poor wound healing, psychological disturbances, mood disturbances. So we just completed a study in adults and showed that we can eliminate DEX. We're currently recruiting patients in a study to see if we can eliminate DEX in children as well. It'll take another 2-3 years for us to finish recruitment. We'll be able to tell, can we get away with DEX for patients receiving highly emetogenic chemotherapy? And if we can get away with DEX, I think that would be a great service to our patients and the parents. The second one is I'm a big fan of intravenous fosaprepitant. As I said, there are NK1 antagonists, and the only 2 NK1 antagonists which are approved in children are aprepitant and fosaprepitant. And why did this interest in fosaprepitant come? The reason is that, at least in India and many of the low and middle income countries, aprepitant comes as a capsule, 3 capsules, 125 mg for day 1, 80 mg for day 2, and day 3. It's only approved for children above 12 years. Children less than 12 years don't have pediatric formulations. We don't have pharmacies which can, make us custom-made aprepitant doses. There is no oral solution. So there's no way you can give an NK1 antagonist to a child less than 12 years. But fosaprepitant is easily available. At least in India, the cost is same like aprepitant. So we thought, why not study fosaprepitant in children? Because nobody had done it. It was widely used in children, and the pharma companies were not interested in doing such studies in children. And it was better because, it was a single dose. Children have an IV line or a central line. You're going to give chemotherapy. Why not just give the fosa with chemotherapy? The child does not need to take tablets for 3 days. If somebody cannot vomit or somebody cannot swallow, especially in young children, it's easier to give an IV preparation than an oral preparation. And as I already mentioned, oral aprepitant preparation for children are not available in many countries. And in US, I was surprised to find that the fosaprepitant is actually economical compared to aprepitant. $320 was $705. The next is, which 5-HT3 antagonist would you prefer? As I said, the first generation 5-HT3 antagonist was ondansetron, then you have granisetron and palnositron. The biggest advantage of palnositron is a single dose, which works for 3 days, whereas ondansetron you have to give every 8 hourly. Yes, palnositron is about 5 times costlier than ondansetron. Ease of administration, IV single dose, ondansetron, you're not sure the child is swallowing or is going to spit it out. And this study was again from India, from Dr. Gauri Kapoor's team, which showed that palnositron is as cost-effective and non-inferior to ondansetron. So this is my current go-to drug. You have to remember that pediatric doses of palnositron is much higher compared to the adult doses of palnositron. So all throughout, I have been talking about prophylaxis. Let's move on to breakthrough CINV. As I said, 40 to 50% of children, despite adequate prophylaxis, are going to vomit in your ward, or you come back to the outpatient saying, the doctor, my child has been puking throughout. What do? The principles of managing breakthrough CINV is that you use a drug which you have not used before, because it's counterintuitive. You're not going to use the same drug which you used to use for prophylaxis. So it was again surprising when we were looking at our patients to see what drugs we can use in children for breakthrough CINV. We realized that actually there are no recommendations. The recommendations which are made from pediatric oncology group of Ontario stated that you can either use olanzapine or metoclopramide for breakthrough vomiting in children. However, these recommendations were based on no studies, no randomized data. So I was even surprised how can a guideline recommend a drug in children without the basis of any safety or efficacy studies for treating breakthrough CINV children? So that's why we decided, let's do a study comparing the two drugs which were recommended by the guidelines. So we compared olanzapine with metoclopramide, and this was also the first randomized trial with olanzapine in children. And we clearly showed that if you gave olanzapine, almost 72% of children with breakthrough vomiting did not develop further vomiting, compared to about 39% in metoclopramide. So olanzapine became the standard of care for treating breakthrough CINV. This is for nausea, and almost 60% had good nausea control. And then recently, just 2 weeks back, the POGO guidelines were published in Pediatric Blood Cancer, which has now recommended olanzapine as a drug of choice for breakthrough CINV in a patient who has not received olanzapine. I said you can use olanzapine upfront. We don't know what we would do in such a situation. I think probably you have to go back to metoclopramide, because olanzapine is not going to work in patients who have already received it in the past. But olanzapine is not a safe drug. It can be tricky. Sometimes the patients in our study, almost 1/4 of the patients were drowsy. The parents are going to complain that my child is sleeping throughout the day. So try to give the dose during the bedtime. It's only a single dose. Also monitor your blood sugars. Sugars can shoot up, and sometimes if your child is on steroids, your sugar can shoot up very high. Extrapyramidal symptoms are a big worry with antipsychotics, but fortunately, we didn't see much with our children. Otherwise, overall, the drug is safe, but watch out for drowsiness and hyperglycemia. So as I come to the end of my talk, there are certain clinical pearls which I've already mentioned, but as I said, the interaction between NK1 antagonist and chemotherapy toxicity, although described theoretically, I haven't seen in my clinical practice. I've been using this drug for more than a decade. I did say that you have to give prophylaxis, but the main point is continue the prophylaxis for at least 72 hours after completion of chemotherapy. So don't stop it. So if you have used some drug like palnositron, that works for 72 hours. But if you use ondansetron, don't stop. Just don't give ondansetron, which has a very short half-life. Continue ondansetron for 3 days after completion of chemotherapy. I've already mentioned in children receiving olanzapine, look out for sedation, monitor the blood glucose. The doses of palnositron in children are much higher. It's like 0.02 mg per kg, going up to a maximum dose of 1.5 mg if you're less than 17 years. Don't ask me why after 17 years the dose comes down to 0.25 mg. I think it's arbitrary. So if you are 16 years, you get 1.5 mg of palnositron, but if you're 17 years, you end up getting 0.25 mg. Again, the dose of phosphatidylic varies. The common dose used in adults is 150 milligram over 30 minutes. And the same dose is followed in children about 12 years. But in younger children, up to 4 years, it becomes 4 mg per kg. And you give it over 60 minutes, and less than 4 years, you use 5 mg per kg. This is because phosphatidylate is not metabolized well in children. So you need higher drug level, more drug doses to maintain a higher drug level. And as mentioned, if somebody vomits in one cycle, you should not say, okay, Venkat said that, 2 drugs is enough for moderately hematogenic. I'm going to continue 2 drugs. No, if somebody is vomited with 2 drugs, that's not enough. There are certain chemotherapy agents which are borderline. They're like 75%, 85% hematogenic. You still call them moderately hematogenic. But in many patients, they might behave like highly hematogenic. So in such case, if you're using 2 drugs, move to 3 drugs. And similarly, at highly hematogenic chemotherapy, with 3 drugs, if your child is vomiting, move on to a 4-drug highly hematogenic chemotherapy. Multi-day chemotherapy, please repeat the palnositron. If you're using palnositron on day 3, if you're using ondansetron, you use daily. We currently don't have data to know whether you have to continue apipitin in patients who are getting multiple-day chemotherapy, say a 5-day or 6-day, or do you have to repeat phosphatidylic? We don't have data, so it's not recommended to repeat apipitin or phosphatidylic, which is what I've mentioned here. And this is an interesting tool. Nausea, as I said, is very difficult because children express nausea in different ways. So if you use an adult tool of a visual scale from 1 to 10 and you ask a child from 1 to 10, how would you rate your nausea? Probably a 10-year-old or 15-year-old would tell, but a 5-year-old is going to look at you confused. So these are facial nausea tools. That's the reference which is given there. It's called the pediatric nausea assessment tool. So if you are doing a study on antiemetics, I would recommend that please use the PNAT score. It's been recently validated in Hindi as well in India, and hopefully it should be validated in other language. So it gives us a common language for research on nausea in children. So what are the unanswered questions? I've been telling you about all these unanswered questions throughout my talk. We don't know what is the ideal dexamethasone, and I don't know whether we really need dexamethasone. We don't know whether we have to, if we have to repeat NK1 antagonist in multi-day chemotherapy. We don't know what would you use for treating breakthrough CINV if you use olanzapine as prophylaxis. And as I said, all the pharma research occurs in adults. So there are newer drugs called like nitipitan and fosnitipitan. Nitipitan is basically a combination of NK1 antagonist with palnositron. Similarly, fosnitipitan is fosagripitan with palnositron. There is no data for use of this drug in children. They are very expensive in adults as well, and they're not commonly routinely used in practice. And all throughout, we have been only talking about a doctor's perspective and how do we feel and what drugs to use. We really don't know what patients feel and their parents feel. There's very less data on patient-reported outcomes in CINV. We might say, oh, it's just a grade 1 vomiting or just a grade 2 vomiting. It's just 3 or 4 episodes of vomiting. The child is fine. That should be okay. But try coming to work with a grade 1 vomiting or grade 2 vomiting. That is even with 1 episode of vomiting, you will not be able to work. So no child should have vomiting. So let's not trivialize, something as just grade 1 or grade 2. So we need more data from, regarding patient-reported outcomes on CINV children. That is very important. So to conclude, ensure that you follow guideline recommended CINV prophylaxis for all children. And currently, the Pediatric Oncology Group of Ontario guidelines are the standard guidelines. I would say that all chemotherapy templates used in the hospital should also have an antiemetic built into those templates so that they are ticked and they are not missed. Use a 3-drug prophylaxis of a 5-HT3 antagonist like ondansetron, palnositron, or granisetron with an NK1 receptor antagonist like fosaprepitant or aprepitant with the steroids for highly hematogenic chemotherapy. For a true drug prophylaxis, use a 5-HT3 antagonist with steroids. And if somebody develops vomiting on these drugs, you can use olanzapine for treating breakthrough vomiting. Thank you very much for this opportunity.
Thank you, Dr. Venkat. Caesar, would you?
Dr. Nita, I can't hear you.
You can't hear now?
Now it's better, yes.
Caesar, are you? I think by the time Caesar comes on, there are a couple of questions in the chat box.
Yeah, we can take them.
Can take them. So there's one question.
I agree with the first question. If you're not a SEOP member, please join SEOP member, and please also become a member of Global Health Network. And if you are a young SEOP, please become a member of the Young SEOP Global Health. We have a WhatsApp group as well. So I'll put my number, and I can add you. I'll just put my number in, and I can add you to the WhatsApp group.
Yeah. So those of you who are not SIOP members, we request you to join. There is a very discounted membership for LMICs. And 2, once you join SIOP, they will be asked to select what are your interest areas. In that, do select SIOP Global Health, because Global Health looks at all aspects of cancer treatment and prevention, palliation, etc. in the LMIC settings. And under Global Health, you do have multiple groups. So like Dr. Venkat has put out, one is Young SEOP, another one would be nursing, there is nutrition, palliation, a lot of other centers, including partnerships. So do select your choice so that you have access to such teaching training programs. So now coming back to the question, so DEXA for breakthrough vomiting. A child comes to the casualty with breakthrough vomiting during the day, difficult to use olanzapine, what should we use?
So as I've already mentioned, the philosophy or principle of breakthrough vomiting is use an agent which is cross-resistant, that is which a child is not caught. So if somebody is already on DEXA, I'm not sure giving DEXA is going to stop the breakthrough vomiting. You have to continue. So if you have given DEX, you have given ondansetron, you have given aprepitant, and the child vomits. You don't stop those three agents. You continue those three agents, and then you add olanzapine. If you can't add olanzapine, you can use metoclopramide. But you are anyway going to give the DEX for another 72 hours since the last dose of chemotherapy. You need to use an agent which has not been exposed. And currently, the two common agents are olanzapine or metoclopramide. And those in LMICs, we have domperidone or domstal, which is not available in US. So that's one more agent to use. But do not stop your prophylactic antiemetics if they are being used when somebody levels. You have to add on. It's kind of an add-on antiemetic for breakthrough. And as I said, olanzapine is safe. The dose is 0.14 mg per kg, rounded off to the nearest 2.5 mg. It comes as a 2.5 mg tablet, and you can easily split the tablet into half, so you can get a 1.25 mg. So you can go to the nearest. So various studies, our studies and Dr. Bakshi's studies have shown that 0.14 mg per kg gives reasonable control of vomiting in children.
Yeah. And can we repeat aprepitant? If yes, in how many days?
So we don't have data for that. That whether we can repeat aprepitant. Dr. Bakshi is going to do a study on that. So nobody knows whether to repeat. There are some studies in adults which have for multi-day chemotherapy which have continued aprepitant. That is day 2, day 3, day 4, day 5. So we really don't have data on that. And also like to say that if somebody hasn't got aprepitant or fosaprepitant, and for example, they have a 2-drug, they got 5-HT3 and steroid, and they develop vomiting. You can't give an NK1. NK1 doesn't work after somebody is vomited. So NK1 antagonists like aprepitant and fosaprepitant are not good for breakthrough. Although the recent PROGO guidelines for breakthrough says that you can use it, but there's no evidence for the same. It's not used in adults. I don't think so. It's going to work in children as well. So don't use NK1 for breakthrough.
I think a couple of questions have been answered. What about patients
Yeah.
in MEC? Can we alternatively use olanzapine in MEC as well?
So if you could see, if I could, I'll just share my slides. This is DEXA and what is the question again?
DEXA in ALL.
Yeah, so generally we are scared of using steroids in patients with acute.
Do you want to ask? I think maybe she meant.
I know, guys. She asked.
Huh?
Yeah, no, she asked the same question around as well. So I know what she's asking. She wants to know that already children get a lot of cumulative steroids in ALL, so more ALL is more long-term toxicity. So can we replace? My screen seen, yeah. So if you go to the POGO guidelines, you can replace steroids. So you can use if you have a moderately emetogenic, and if you can see my pointer, if you are unable to receive DEX, you can just use 2. It's like a buffet lunch. You have 4 drugs to choose. You can use 5-HT3 plus fosaprepitant, which is a choice. If you are highly emetogenic, if you can't use DEX, you can use fosa with olanzapine with palbociclib. So this is the DEX solution. So you can eliminate DEX and you can add the other drug. That's perfectly all right. But the POGO guidelines doesn't say that in children with acute leukemia don't use DEX. But with concerns, you can use other antibiotics. There are concerns.
I think Caesar, do you want to make any comments?
Yes, thank you. Thank you, Nita, and thank you, Venkat, and thank you all of you that have been participating in the meeting. I think that this is one of the meetings with the highest audience, and I think that speaks to the quality.
Caesar, you're muted. Yeah.
Okay, thank you. What I was trying to say that this is one of the meetings with the highest audience, and I think that we appreciate the help and the participation of all the colleagues that they are present, and obviously that speak about the quality of the speaker today, Vinka, that has been a driving force in this particular topic, and also in other areas in global health. A little bit of executive comment for the group is that I think that we joined the voice of many of you to participate in SIOP, to be a member, and I think that that's a good opportunity. And obviously, for all the colleagues that they are here and the other members and participants to continue coming to these meetings. The other thing that we are planning to do is to communicate with the different presidents of the continental branch in order to try to get a little more fluent communication with them, in the sense that will be a good idea to have a couple individuals from each particular branch to participate in a more permanent way. So in that way, we will have a little more fluent communication between what we can do here in our working group with each particular continental branch and vice versa. So we can receive some communication from them to us, and that open different channels of communication. And the idea in some point is that the people that they are receiving this information may start to consider, okay, we can do a project here, we can do an interesting development here. For example, what Venkat was saying, there is a project to get a new antiemetic on board, so how we can participate in a study. So that will open different opportunities, not only for the PIs of future PIs of project, but also for participants in a more wider range of opportunities. And I think that that's the message. We will try to continue in our working group to do a little bit of continual updates, like the excellent update that Pinka has done about nausea and vomiting, and also different topics that would be more aligned with what the community wanted. But also, we have to realize that we will have to do a little bit of executive areas in our meetings, and we will try to keep the meetings once per month, sometime vacation time, things like that may produce a little bit of interference, but that would be the goal. Thank you, guys.
Yeah, thanks, Isa. I don't think we have any more questions. A couple of questions have been taken up already. I think there's a question for you, Tessie. So there's a query regarding virtual PSYOP meetings. Is there any benefit of membership? So that I'm not sure. I couldn't find it on. Yes, I think even there it's a difference. So even in the registration list, you can find. Tessie, do you want to say anything?
Sorry, Nita, one more time the question. Is there a benefit for registration?
When you are attending PSYOP virtually.
I have to double check the rates this year, but the virtual attendance is already quite discounted.
It's a difference. I just looked it up. So I put the link on the chat box. So if you are a member, there is a virtual fees difference is definitely there lower down for non-members. I'm not sure about members that you can. PSYOP member LMIC, I think it's 100 Canadian dollars. Whereas
yes, yeah, there is a difference. If you're a member, for virtual attendance, it's 510 Canadian dollars, and if you're not a member, it's 550. So it's a small difference.
Yes, and if you are a member from an LMIC, it is 100 Canadian dollars. Right?
Right, correct. Yep.
So there is a difference, everyone. Please join. And
yeah, if anyone needs a visa support letter for Canada, they can email the PSYOP office.
Yeah, true. So I think there are no more questions. Do you want to wind up the session, Cesar?
I would like to ask the participants, if that's okay for you guys. Do you want to put your camera 1 second? If you feel comfortable that we take a picture of the group, it looks really, really nice. All of us here. So I will get a couple seconds to see if do you want to compare to real life. Otherwise, if that's okay, we take a picture of the whole group, and I think that is very interesting. Okay, so I think that there are a couple of colleagues that they join us. Let's see how we can take the picture here. Thank you for those that they're working in these things. Excellent, guys. Thank you very much. Thank you, Vinka, and thank you, Nita. Thank you, Tessie. Thank you, Nelia.
Thank you.
And all of you for participating, and have a wonderful weekend.
Yeah.
Take
Bye.
care, guys.
Thanks again. Thanks all for
Bye.
joining.
Thanks a lot. Thank you.
For all the support from the SIOP office. And till we meet next month. Bye-bye.